Welcome, my friends, to the Bob and Brad podcast. My name is Mike Keenitz, and I'm a PT assistant. Today, I am interviewing RT Hill and Niraj Vora from the Stride Shop. Both are physical therapists, and they own a running clinic in Baton Rouge and New Orleans, Louisiana. So we are going to talk about different running injuries and how to work through them and different exercises you can try to fix these problems. So without further ado, here are the gentlemen from the Stride Shop. Well, welcome to the show. We got RT Hill and Niraj Vora.
Thanks for having me. Hey.
You guys are both owners of the Stride Shop?
That's correct. We started in New Orleans and then recently opened in Baton Rouge, Louisiana.
So can you guys describe your backgrounds and your clinic and what type of services you provide?
Yeah, you want to? I'll kick things off there. So, RT Hill, I graduated from PT school in New Orleans. Went to LSU Health Sciences Center and then did an orthopedic residency through University of St. Augustine. I kind of bounced around as a contract travel therapist for a little while until came back down to New Orleans and worked at a baseball pitching academy called Top Velocity. We would see guys from high school up to some pro level athletes. And while I was doing that, I was also working in a sports medicine clinic here in the city. That's where I met Niraj. And we worked together for 2.5, 3 years, Niraj. And then I think it was one of those kind of deals where, as I would put it, you were kind of at the mercy of the powers that be, a little bit above you, more of a corporate system, I would suppose. And so we would have 2, 3, sometimes 4 patients that you were seeing kind of at a time. And so we got together, said, maybe there's a better way that we can do this, where we can spend a little bit more one-on-one time with some clients. You get into those kind of situations and you see how another person practices, and if y'all would jive very well together, and it turns out we would do a lot of co-treats. And so through enough threats between the two of us, like, man, we're gonna break off, we're gonna start something different. We started the Stride Shop up about 3 years ago, 2019, and both of us were athletes. I played soccer and baseball. Niraj, soccer guy as well, and we had kind of transitioned out of that into more of, our new competition against ourselves and to a certain degree other people is going to be running. And we picked it up and developed an interest in that and focused a lot of our treating and rehabilitation skills towards that. And so that's kind of the niche that we targeted whenever we started the Stride Shop. It was to let's get in this underserved group of people that are here and kind of give them a specialized treatment plan that's maybe not a generalized deal. There's a lot of therapists that I think can obviously treat running injuries without a doubt, but I don't think there's kind of a price you can put on the number of volume of injuries and diagnoses that you see, right? If I see 20 people with shin splints, I'm going to be a little bit better when I've seen 40 people with shin splints, when I've seen 100. And so, I think we've kind of now got to a point to where, because that is the bulk of the type of patients that we see, we've been lucky enough to develop a little bit of word of mouth around New Orleans and Baton Rouge area and spend a whole lot more time, helping people kind of all the way towards their goals. Whereas I can speak for myself here. I think in kind of the last setting we were in, I got pretty good at getting people about 75% of the way there. And it was kind of, look, you're good enough to discharge. Sometimes you'd hear that they went out and met some goals. Sometimes you never hear from them at all. A lot of times they cycle back into the PT, realm kind of deal. So I think we've hit a fun kind of niche, one practice model, and also group of people that we get to work with and enjoy.
Niraj, is all this true?
You made all that up. I don't know what it is. I think he covered it all. We, I think as PTs and PTAs in our field, we kind of have to work with what we have, and unfortunately, what we have is that we're measured in a lot of ways by productivity rather than how much better our patients get in a lot of places. And we weren't quite satisfied with that, and so we're just trying to provide something a little different.
Yeah, I would agree. Most PTs are kind of that I've talked to lately of kind of getting out of, most mainstream places to work now.
Yeah, I think it's a trend that we're going to see in our profession a lot, and I think healthcare in general is probably going to trend that way at some point when people realize the value of time with their healthcare provider, and so it'll be interesting what happens with our profession specifically. But yeah.
You guys want to mention your website and where people can find you on social media quick before we get too in depth here?
Sure. Our website is thestrideshop.com. We've got blogs and some free resources and a newsletter that we think is cool. And we've also got an online course called video series called Building a Resilient Runner that we think stuffs a ton of information into some 10-minute segments that can be helpful for runners of all abilities. And then social media, we are at The Stride Shop on Instagram and The Stride Shop on Facebook.
Do you guys treat just people in person if you're seeing them?
We do both. The bulk is certainly in person, but we do treat virtually when need be, and sometimes when word of mouth allows us to do so. But yeah, we do treat virtually.
So I was looking at your site a little bit. So you guys do you do just normal physical therapy, treating runners, and then also like gait analysis for running and things like that, right?
Yeah. So for you had asked this, and I think in my long description of what it is, what our background was, I missed on like what we kind of do. So we do the rehab portion of it. We do a performance training kind of thing. So people have kind of made it past that rehab stage and are looking to maybe get like a personal best or looking specifically for some running form kind of stuff. So we do strength training for that kind of thing. Some gait analysis is a deal we do. And then we see kind of the gambit of everything else. Like I said, we met at a sports medicine clinic. So primarily orthopedic injuries, orthopedic diagnoses. And then I've got a little bit of a background in some chronic pain and kinetic neurology kind of stuff.
Okay. So I think we'll get into the meat and potatoes here of all these different running issues. The first subject we're going to talk about is shin splints. So shin splints are a very common running injury, which can occur in the front or back of the shin bone. What approach do you guys use to treat this injury?
Yeah, shin splints are a challenge in a lot of ways. I think that we have to approach them with caution. A lot of what we learned, I think, as we treated more and more running athletes is that we probably didn't do a great job earlier in our careers of being aware of stress fractures. And so I think that just being on the radar is a big deal. And bone stress injuries are this huge spectrum of, starting with the least severe up all the way to the black line that you see that tells us there's a fracture. So, and all of them need to be treated with caution, especially the ones in high risk sites. So shin splints tend to be along the tibia, the shin bone in the front of your lower leg, either on the kind of outside or the inside. And so if we're able to first really dig into somebody's kind of subjective history. So are there any changes recently in the volume of their training, the intensity of their training, footwear, the surface that they're running on? Are they a newer runner, or do they have experience with running? All those things start to inform how we approach somebody who's telling us that they have shin pain before we even touch them. And then with that, we can start to develop a little bit clearer lens of, all right, this shin pain doesn't really have any mechanism in terms of their training that spiked or anything that changed. So it may be that we approach it a little bit differently. Whereas if somebody said, a lot of times, when COVID started, I just picked up running and I was up to 40 miles a week. And those you're radar kind of starts spinning, and you are much more aware of something that may be more of a severe case. But shin splints are really painful and can be really kind of a nuisance. They don't tend to like get better quickly. But the things we want to look at generally are people's feet to start. What is their callus pattern? Where do they tend to bear weight on their foot when they're out of their shoe? What their motion is at their big toe. If they don't have appropriate big toe motion, that can cause a lot of issues with how they load their foot. Then we talk about, do you have toe dexterity? So I think toe yoga has become kind of very popular in a lot of places, but can you take, your big toe and lift it up in isolation, and then your other 4 toes and lift it up in isolation? And that's as simple as saying, can you make a fist and open your hand? Well, yeah, everybody can. As somebody who's taken thousands and thousands of steps on a run, we like to see that people have control of their foot to efficiently disperse loads. So if they can check those boxes, then we start to go up to kind of ankle mobility. We start to look at strength of the calf and the peroneal muscles. And obviously we want to poke and palpate where somebody's pain is. If it's kind of this diffuse pain that's, kind of the bottom half of the shin, it leads us more likely to believe that it is muscular in nature and shin splint related, versus if there's this focal tenderness over one spot, it may make us lean a little bit more towards there being something related to the bone. And when we talk about the lower leg, the kind of anterior cortex, so that very front part of your shin is a pretty high risk site because it doesn't heal well. And that doesn't have great vascularity in some portions. So we have to be really cautious when somebody says, yeah, I got these shin splints. It's been really bad. I've been able to train through them, but it's just getting worse and worse. So our ears perk up when we hear shin splints for sure.
How often is it actually a stress fracture? Do you have like an estimate?
It'd be hard to put a number on it, but I'll say that it's probably more than I would suspect. I mean, looking back, before we started treating runners exclusively, and I'll speak for myself, seeing endurance athletes, runners in the clinics, it just wasn't something that was on my radar. I didn't think that it was something that was very common. But when you get into this population, it's more common than we think, and I think it's missed a lot. And I think that people end up in that cycle that we see where people come to therapy for a couple of months and then go away, and then they're back a couple months later. And I think those are situations where we're just missing something. So bone stress injuries are more common than we think, but they also, they tend, I'll say this very generally, tend to present with people that have that, like, things add up, something changed in their training. You can tell, like, they have poor sleep habits, or they have a very stressful job, or they've got young kids and they don't eat well, and all these things that contribute to more severe injuries. So it's really, really important that we dig in, not just like, what shoes are you wearing and how far do you run? We want to make sure we're digging deeper to give us clues to see what may contribute to some of those bony injuries.
Go ahead, RT.
I was going to say, I'll hop in there for a second on this to kind of touch on what you said about, how often are we seeing this? I can tell you, same Niraj. Like, I feel like I missed a ton of these over the course of it all until I started like kind of looking for it specifically. And now I'm referring people out probably a few a month that I'll end up seeing that I'm suspecting it, to the point where I'm like, yeah, let's go ahead and make sure we get some imaging. Because the way that you're treating that versus a muscular injury is entirely different, right? You're offloading that bone tissue if you're in a stress fracture type situation, and so now I've just become a whole lot more aware of that risk, because it is a continuum, right? We tend to think of that shin splints into a bone stress reaction into stress fracture type of thing. And when it comes to subjective things, I think there's those certain key things that again, make your ears kind of pop up, right? Young kid that all they do is run cross country, right? Never played any soccer, never played any kind of bounding or jumping sport or anything like that. That bone's just been stressed in one manner every day that they've ever gone out and do anything. And that puts them at a higher risk, right? That bone hasn't built that torsional kind of resiliency to be able to tolerate those kind of things that you get with like a soccer player or a basketball player or something like that. Eating habits, poor sleeping habits, stress at school, those kind of things. So I would say for me personally, just the more like high school young kids that I've worked with, those are the ones that I pay a little bit, not a little bit more, I pay a whole lot more attention to that population with it.
Would you say if someone is coming off of a stress fracture and they're healed up, it'd probably be beneficial for them to try running either in different footwear, wearing different shoes, like their normal shoes one day and then a new shoe the next day, just to get different types of feel on the feet, or maybe do like more off-road versus on-road just to get a variety?
Yeah, so then you get pretty deep into like bone loads and where somebody's like, it may be different for somebody who's a heel striker versus a forefoot striker as to what footwear they might benefit from if they had a tibial stress injury or a fibular stress injury. And then speed is really important too. So I think the difference between somebody returned to running at close to 8 miles per hour versus closer to 6 miles per hour, the tibial bone loads decreased by about 50%. So you want to be aware that you're really clear in what return to running looks like for these people. The biggest risk factor for having a stress fracture is a previous history of stress fracture. And so you get deep into how long it takes to reform bone and osteoblasts and osteogenic exercises that kind of put you on the right track. But footwear is important. And so if somebody has been in something like a shoe that's minimalist and has a history of injuries, maybe you do have to start them in something that has a little bit of a higher drop and shifts loads a little bit away from the lower leg. But it's very individual as to how somebody is structurally, how somebody runs, where their heel strike pattern is. Cadence is a big thing in running and running injuries. So when we talk about return to running off of bone stress injury, we have to consider lots of things. You mentioned like different footwear, and that's huge. Having somebody wear more than one type of shoe within a week, so those who wear more than one type of shoe, 2 or more, are at significantly decreased risk of injury. So even if you're healthy, it's probably a good idea to build some tolerance to different shoe and footwear types. We tend to see people who are like, I love this shoe, I bought 6 pair of it. So
Yeah.
because the model changes and I'm going to be screwed.
People are trying to search eBay to find the gym one of a certain Brooks pair.
Yeah.
I say this because I had a guy like that earlier this week. It's like, yeah, I found 3 pair from some guy in Ohio. I bought all of them.
Yeah. And sometimes those people are okay. They never have a problem. But yes, I think that being tolerant of different stresses on your foot and lower leg and whole body in general are great. In terms of surface, I think it's also important to recognize that like running on a treadmill will increase the load at your lower leg and ankle versus getting outdoors. So somebody with an Achilles injury or shin splints, I'm probably not prescribing their return to run on a treadmill versus if the other option is flat outdoors on the sidewalk. So there are a lot of variables to consider.
Sure. Are there any recommendations for like just someone at home if they have shin splints, like exercises or stretches you guys would recommend?
I'll hop in there for a second. Niraj touched in at the very start of it, talking about like that foot control, right? That toe dexterity and that ability to manipulate the foot and having a sound, communication signal from the brain to the foot. And I'm going to give a plug to a tool that we use a lot, and it's called a Mobo board. Created by a guy named Jay DeSherry from here in New Orleans, but essentially it's similar to like if you've used a fitter board in the clinic that goes plantar flexion, dorsiflexion, or inversion, eversion. This puts it on an angle that strengthens into pronation, supination. And it has a hole cut out where your toes would go. So you have to anchor down with the great toe, and you stabilize in that plane of motion, that control, in pronation, supination. And so that is, man, I can't tell you how many of those that we've suggested to people, and we're incorporating in a ton of our, or at least I am incorporating into a ton of my treatment protocols that I have for people. I think that's one of the best things for it, because there's so many different varieties of different balance drills and things like that you can do on it. And you see those individuals that try to bypass the shorter muscles, bellies that are on the bottom of the foot. What they'll do is they'll claw with the flexor longus muscle group, and when you do that, it creates a more rigid midfoot, and so you hit with more force, and that force has to go somewhere, and a lot of times it's in the shin. So all that to say, this board, I feel like, helps to, one, establish a good foot control along that great toe and the true foot supporting muscles on the bottom of the plantar surface of the foot. So that's kind of where I start a lot of those individuals at.
I've never seen a board like that.
Yeah.
Huh,
yeah.
Interesting.
Man, it's fantastic.
All right.
I wish we got some money for something like that. We don't.
You gotta work out an affiliate with them. Come on, guys.
Yeah, I should work out something.
Mobo, if
the
you
guys
hear this.
from New Orleans, we can talk about old, watering holes or something around here.
All right. The next top, is that good for shin splints, or you guys have anything else?
No, that's great.
Okay. We will go on to heel pain when running. So heel pain is very common among runners and even non-runners. So what is your approach to working with someone who has heel pain?
I'll jump in there. So I think first thing to kind of consider and be aware of is that not all heel pain is the same deal, right? There's a lot of differential diagnosis that can happen in that area. For instance, insertional Achilles, right? So where the Achilles tendon actually inserts into the bone, that's a different treatment and different approach than someone who has like a plantar fasciitis or a fat pad displacement or like a retrocalcaneal like bursitis or something like that, right? So the approach needs to be individualized. And another one of those that I feel like gets kind of lumped into that heel pain or Achilles tendonitis is, again, is it an insertional or is it higher up, more in the tendon or the musculotendinous junction? We mentioned before, the way that you treat a bone injury is very different from the way that you would treat a tendon or muscle, right? So in one of those diagnoses, when it's more in the tissue, you want to load that. It needs that tension across it in order to build up more resiliency and build up. If it's where it's on the bone, right, we're trying to unload that a little bit and just give it a breather so it can go through its inflammatory cycle, and then you can progressively get back into it, right? So the initial approach is, again, it's not all of it's the same. So you got to work on your skills, and seeing multiple people with different types of heel pain helps with that kind of process instead of just putting it under an umbrella term. In terms of how we then go into the differential diagnosis and some of the objective things that we look at, similar to stuff you see with shin splints, honestly, a lot of, do you have toe dexterity and splay? What's your ability to activate the digitorum brevis musculature? How's your peroneal strength? If I just have someone standing there, and make them actually bring their attention to the bottom of your feet, like, where is your weight distributed? Because very few people that come into the clinic, if I say, where's your weight on the bottom of your foot right now? They're like, bottom of the foot. And you have them start thinking, all right, well, is it on the heel? Is it on the back portion of the heel? Or are you hanging out towards the ball of the foot? Are you hanging on the right side? And very few people, I think, have this volitional awareness of, like, where am I actually putting my weight on a day-to-day basis while I'm just standing for hours at a time, right? So part of it is bringing some attention to that kind of thing. And then we're going to test it. I want to know what you can do. Can you go a double leg heel raise? If you can do that, fantastic. Can you do a single leg heel raise from a flat surface? Fantastic. If you're able to do that, well, then let's put you in a little bit of a deficit and see if you can activate and that tissue can tolerate it when it's got a little more force on it. If you start going through those criteria based, right, and you improve at different segments of rehab or during an evaluation that you're able to do those kind of things, then we kind of know, one, how serious is it? Where is a lot of that pain potentially coming from? And then we have a good way of gauging, well, is it appropriate for you to actually get back to running, right? If you're not able to do a single leg heel raise, it's definitely not fair for me to be like, well, go try a quarter mile and see how you feel at the end of it, right? So that goes into us, and I'm sure we'll get into it at some point, like what our criteria is for someone to get back to running. For me, being able to do a series of some single leg heel raises is an important part of that.
Sure. Is there any? It's too individualistic, I would say, to recommend anything, at home for people to try. I mean, besides the test you just discussed.
Well, I think that there are things that you can try, but there are things that you probably shouldn't do. And I think traditionally, in a lot of clinics, and I've been in these clinics and I've done this in the past, it's like everybody with pain on the bottom of their foot is treated for plantar fasciitis. You roll it out, you do some toe curls on a towel, or you pick up some marbles and drop them in a cup, and then you get massaged, and that's and we stretch our calves, and we hope that
stretching, right?
Yeah, we'd hope that treats your heel pain, and in fact, kind of grabbing a towel or picking up marbles with your toes is kind of doing the opposite of what it kind of reinforces a lot of the patterns that probably led to heel pain. You're starting to use those long toe flexors that run up into your shin and cause shin splints in a lot of cases. When in reality, we should really be training to use those short toe flexors of your foot. And if massage and stretching feels good, I think it's great. I don't see any problem with it. But I think we treat plantar foot pain or heel pain way differently than we do in the rest of the body. We don't just hope that we stretch something and it kind of goes away over time. I think we need to treat it just like we would a quadricep strain, right? Like after symptoms are calmed, we want to make sure that quadricep is really strong. And so how do you make the bottom of your foot really strong? And so, the exercises that we start to have people do are, again, one, start with the toe yoga. Two, we can add a band to the lesser four toes and have people just push down with their band. They don't grip with it, but if they can push down from the proximal joint, then you start activating the flexor digitorum brevis, and you get you almost feel this crampy sensation right in the middle of your foot. It kind of tracks along the bottom of your foot the same way the plantar fascia does, and so we have to reinforce it. And then if people can tolerate it, like RT said, we get into those single leg activities, but we cue really, really hard that you're going to use your big toe. You're not going to grip at the ground and try to find stability from your lesser toes. You're going to keep that foot tripod, we call it, under the little toe with all the big toe and the heel, and have some awareness, like RT said, of what your foot is doing, as opposed to just trying to pick things up with your toes and stretch things.
And stretching it.
Yeah. Do you guys have people, as long as it's not acute, do you have them try to spend time maybe being barefoot or less cushioning shoes just to naturally strengthen their foot up then?
Yeah, absolutely. The way that I tend to present this to clients that come in is, if you think of the bottom of your foot as a antenna, tells your brain, hey, this is the surface that I'm on. This is the angle our foot's turning at. This is the way. Here's how the support is at the bottom of our foot. The stronger that signal is, the better, right? And the best way to get that is to get as many pressure points, as many tactile points on the bottom of that foot as possible, because that's more data that the brain has to use to develop a connection between the head and the foot. If you're in a shoe that has a really high stack height, right, that space from the ground to the bottom of the foot has this kind of dampened surface that it has to make its way through. So you're kind of putting the brain and the foot at a little bit of a disadvantage at that point. So for most of the people that I treat, we do a lot of the stuff barefoot. So
yeah, I kind of had, when I first started running again during COVID, like everyone else.
Yeah.
I was having some it never bothered me besides when I was running. And then later on, I started getting into more flat shoes and minimalistic, and I don't have the problem at all anymore. I was lucky it wasn't like ever terrible, but that's just what I did, and it went away naturally. And for our listeners, I think that was a dog in the background, not some.
That's fine. Sorry.
That's fine. At first, I was like, "What is that?" It was just a dog. Don't worry.
Just a dog. No, I think it's not that there's one way to treat heel pain, but I think that there are bad ways to treat heel pain, and there are also, we see clients all the time where people have plantar fasciitis and their provider or whomever they go to see tells them you should never walk barefoot because it'll hurt too much, or you can't wear flip flops ever. And like you said, maybe in an acute case, we aren't just telling people to go walk on the beach barefoot when they've got plantar fasciitis, but we're not in the business of having people like avoid things for the rest of their life for fear of having their pain return. If we can do things the right way, you should be able to do all those things.
Right. Yeah. I have an uncle who he's overweight, middle age, and every 2 to 3 years when I see him on Thanksgiving, he's always talking about his heel pain coming back. He loves ultrasound.
Yes.
And his super cushioned shoes.
Yes.
When he says it to you, he says it not like asking for therapy advice, but just kind of putting it out there in case you want to willingly give it to him.
Yeah, he was upset last time because his new therapist gave him Ianto, or no, his new what's the little medicine they put in? I can't think of what it's called.
Yeah, that's right.
Iantophoresis. Yeah, they gave him that, and he's like, "No, I want the ultrasound."
That's great.
Got riled up.
Thanksgiving.
Yeah, coming up. So I think we're gonna get on to strength training for runners and why runners should do strength training, because back in the day it was not recommended. So what do you guys recommend for strength training?
All right, I'll jump in on that one as well. Yeah, so that tide has turned. It used to be, if I'm a runner, I just need to run, and that's all I need to do. And I think that has now become pretty well documented and pretty well shown that runners need to be doing some form of strength training, not just from a performance standpoint. If you want to run faster and have a better running economy and run longer, strength training is going to help for that. But then, while you can't say, well, this is 100% going to ensure that you don't get an injury, strength training helps to build a resiliency in your tissue so that you are able to take on more of a load and more activity without overloading your bones and muscles and joints and things like that. And so I think runners that are out there that are only running and never strength training, they're missing out. I think they're putting themselves at a huge disadvantage for those reasons that I said, right? Improve running economy, reduce fatigue, bone health, improved anaerobic endurance, right? Improved max speed. And it helps to break up a lot of times the monotony of just running all the time. So I'm for it. I'm all about it.
Anything you'd like to add to that, Niraj?
Yeah, I think, again, we think about this sometimes in a weird way, like, a pitcher, a baseball pitcher, or an offensive lineman, they strength train, right? They have demands for their sport and they strength train. And the same applies to running. There are demands. The sprinters strength train. Endurance runners should strength train in some sense. Running, it's one of those things where it's, beginners for sure, like the more you run, you see these huge changes right away, right? Not right away, but as you start into running, maybe you can run farther, maybe you can run faster as you start training. But running from the sense of outside of performance we talked a little bit about bone. Running's not really an osteogenic, a bone-forming activity. And so if you're just pounding on bones through this one form of input, you're probably at higher risk. We know you are as a high school athlete. If you specialize as a runner, you're at much higher risk, 7 times more likely, I think, to sustain a bony injury. So, from a viewpoint of healthy bones, yes, you should provide some resistance training. And the same applies to tendons, because if all you're providing is this kind of moderate plyometric input to tendons, you're not going to be sustaining tendon health the way that resistance training would as well. So it's like trying a different pair of shoes. It's like any athlete that trains doesn't spend 100% of their time training in their sport. You don't just a pitcher doesn't just keep throwing and throwing and throwing until they get better, right? So I think we just need to approach and look at it a little differently than we do.
Do you guys have any recommendations of like some basic exercises people should do if they're runners for strength training?
Yeah, I think we have kind of a recipe template that we start out with most of our runners, or anybody who kind of comes into the clinic, not just runners. We do some specialized stuff for runners, but basically you're going to do 5 primary movements, right? You're going to push things, you're going to pull things. You're going to do some form of a hinge, squat, and then carry. And so then when it comes to runners, we're specifically going to then do some type of focus on some single leg activity and making sure that we're hitting the calves as well. And that is something in addition to all of the toe yoga and the Mobo balance and, and all those kind of things that we've mentioned already. But yeah, I think if you can put together a push, a pull, a hinge, a squat, and a carry, some form of single leg and a calf exercise, you can have so many different varieties of workout routines that then it's just a matter of, from a physical therapist standpoint, appropriately progressing those exercises and those movement patterns once someone has proven that they have the capability to do so. I think it's Dan John that says that 80% of your training should be geared toward your sport. So about 80% of your training should be running, but then 20% should be dedicated to getting stronger. So if runners can get into the gym a couple days a week, that's a pro. That's a
Yeah.
win.
So you typically recommend like 2-3 days a week for runners?
Depends. If someone, I know there's
Depends
a lot
on
of
mileage and time, I suppose.
depends on mileage time. Are you in the middle of, right? So say someone's in the middle of a training cycle for Boston Marathon, New York Marathon, something like that. If they're in the middle of a training cycle, their focus needs to be more on running and hitting some metrics that they want to there. So we'll have someone do maybe one day a week of training during that time, or like a strength training. Still focusing on mobility work and stuff like that, but we probably take the strength training a little bit lighter during that cycle. But if they're then in the off season and they're not training for a specific race, well, that's a great time to let the body recover from the repetitive motion of running and really build up some power and some strength. So then we're going to recommend, well, let's try and get you in 2 to 3 days a week, and try and build up a little bit more muscular power during those times. So it's where you're at in your training and that kind of deal. But if you're just in an off season, or you're not necessarily looking to run a race or something like that, 2 days a week, 2-3 days a week.
Do you guys recommend, like, during the off season? I know some people, they'll focus more on like lifting heavier during the off season and like more repetitions during in season. Is that what you guys kind of do?
Yeah, I think generally speaking, it's probably a good way to go. I think that as your volume of running decreases, it's a good time to focus on your strength. As your volume of running increases, it's a great time to maybe dial back in the weight room and focus more on some mobility or some mechanics, things on one leg, stability, quote unquote stability exercises, right? I think that that's a pretty smart way to go about it. I think our team mentioned too that when we work with runners, not only those forms of exercise, but if you want to boil it down to the simplest thing, it's that runners mostly are going to use their quadriceps, their calf muscles, and their lateral hip. And so if you've got somebody coming in saying, give me 3 things to train, We don't do an exam. We don't know where, maybe you need the most work, but generically speaking, I mean, I think that if you can train those 3 muscle groups, you're probably going to do pretty well.
Right. Yeah. I've gone back and forth between running and being a meathead lifter, so I'm kind of stuck in this in between. I'm like a very bulky for a runner, but
well, you're kind of one of the lucky ones, though. I think, right, because you're willing to go in and lift heavy weights, which I think can be super intimidating for someone who's never done it before. And then Niraj and I come on to a podcast and say, yeah, you need to get out there and start deadlifting. Okay?
Yeah.
One of the best things that you can do for it. And someone's like, cool, gonna do it. What's a deadlift?
Right. Yeah.
And so I hope that more and more people, runners specifically, get comfortable doing that. So then there's more people to kind of guide you into it. And I hope more therapists start realizing that this is something we need to be doing, right? Ideally, from a physical therapy standpoint, the end of your rehab should look pretty similar to what it would look like if you're going to the gym. That's the main goal, right? Is to be able to set you off into the wild and go in there and do all those kind of things. So, I think we got to take it on ourselves as PTs to get trained up and feel comfortable in teaching the mechanics of those types of things and helping get runners into those positions in a safe way,
Right.
where it's not as intimidating.
I would mention we're not talking about it today, but it's very important to work on your flexibility and mobility too, because I neglected that this last year while training for marathons, and my hip paid for it. So I've been focused on it now, but
yeah, there's only so many hours in a day. And it's like, what do you spend your time doing a lot of times, right? And it's very much a moving target. Like you said, if you spent a ton of time marathon training, maybe you didn't have time to be in the gym as much, and you didn't have time to work on your mobility as much. And then, you get past the marathon and you reassess and you realize, I've neglected this, and so I'm going to spend more time on this. It's a moving target. There's not one recipe that's going to work for everybody, and it's not one recipe that for one person is going to work from year to year. I think it's important that we reassess those things too.
Right. So in New Orleans, we work out of a gym with a guy's name's Brian Adams with Cypress Fitness, and he is he's a personal trainer, but he's got this extensive martial arts background and does some things when it comes to mobility, to your point here, Mike, of just really cool, really profound things. And he has all these sayings, like these analogies. And he gave one the other day. I'm going to rip it off from him right now, but because he was talking to a musician, and he's like, if you're a musician and you can play 3 chords, right, on a guitar, that means you can play songs that include those 3 chords and only those 3 chords. Same thing if you have mobility that's limited to this small amount. If you have this much mobility, you can only do activities that require that much. But if we teach you more chords, now all of a sudden your song library gets wider and wider. And if we give you more mobility and we strength train, or we train those joints in that new mobility, now you have all these additional activities and positions that you can get in and be there safely. And I thought that was, for us down here, I was like, God, one day I'm going to come up with something like that on my own.
That makes good sense in my head. I play music, but I do drums. I don't do guitar. But
yeah, if I gave you one snare drum,
I want more drums than that.
One snare drum.
We're gonna talk about IT band syndrome now. So I kind of have a tight IT band, so I guess this relates to me too. So what is your approach to IT band syndrome?
Yeah, I mean, IT band syndrome again is one of those things that's I think probably approached in a million different ways if you walk into a PT clinic, and I think that there are things that people are like, you should never foam roll. Other people are saying you should always foam roll, and you should stretch your IT band, or there's no way to stretch your IT band. It's useless. And I think that's fine. And we're very much evidence guided as opposed to this is what the research says, so that's the only thing we're going to do. I myself have gone back and forth between foam rolling, not foam rolling, foam rolling. It's pretty painful, and sometimes it's useless. But I think it has its place. If we can do something that it's helpful, I think we should absolutely use it. But really, I think we're going to approach it the same way we do most injuries to start. You get a great history of what has led to this. Has something changed in your training? Do we need to adjust volume or intensity or frequency? Do we need to adjust your surface? Have you been running a ton of downhill? Or have you just recently changed surface where you moved and now you're in this hilly place and all of a sudden you don't have the tolerance for it? So
running a track in one direction,
the
whole time, right?
Yeah,
running on the street on one side.
Yeah, and so you take all these things into account. I think generally speaking, IT band related treatment is going to consist of us making sure we train your quadriceps really well, eccentrically as well as concentrically. We're going to train your lateral hip muscles quite a bit. And I think a lot of times we forget about what the foot and ankle are doing. A lot of times the foot and ankle create things upstream and we forget about what's going on with the foot and ankle that may contribute to IT band pain. So we have to address those things. And then we want to watch you run. If there's this, kind of heavy crossover pattern with your feet where, you're crossing side to side with your feet, it's a kind of a simple cue where we want you to create some width in between your feet to offload your IT band a little bit. And then if you are rehabbing from an IT band injury, you probably would do well to start on an incline. So maybe you do start on a treadmill. It just decreases the force of the quadricep and the knee flexion angle a little bit. So you may start uphill and then progress to flat ground.
Did you say most people? So I've heard people experience IT band pain by their knee, but I've also heard at their lateral hip. What do you guys normally see?
I think I mean, we see both, right? Yeah. And I think you're dealing with kind of the same. It's the same tissue, just in a different location of where it's creating the pressure at, or the compression at. Lateral hip, I think you can differential diagnose it as is it a ischial bursitis? Is it a bursitis on the lateral portion of the hip? But that's running underneath like the tissue that eventually turns into the IT band right there. Down by the knee, a lot of time that's one of those deals where the knee, for all intents and purposes, is a pretty simple joint, right? It's hinges back and forth. It has a little bit of rotational stuff, but for the most part, it's just a hinge. So you look above or below the joint, upstream or downstream, to see what's going on there. And with runners, I think a lot of times looking at the foot is probably where I'm gonna start at there. But in terms of where we see it the most, I'd say it's about even for me. Personally, one of the ways that I'll tend to get in there, you'd mentioned like the gait analysis, Niraj, and looking for that crossover pattern. Kind of what I'm looking for a lot of times in that gait analysis is how much actual like spring does someone kind of have, right? Are they kind of bounce off of the ground, or is it more, are they just kind of shuffling the feet forward? And what that's kind of telling me there is if someone's just basically just kind of shuffling and puttering, you're just pulling at kind of the top of that hip up there. And that just creates this disconnect, or this imbalance where we start pulling that IT band forward a little bit more, which can then translate a little bit further down the hip. So for me, I want to see someone that's really, really creating that spring out of the Achilles, absorbing energy, expending it. They've got some good posterior chain activation that's propelling them forward, type of deal that I would want to see out of someone that's dealing with an IT band issue.
Yeah, I would say a common thing amongst a lot of runners, and probably me last year, because it was the first time I did heart rate training. So I had to slow down my gait. And I think I was just really lazily running. And I think I was shifting more laterally versus engaging my buttock. Yep. So all that force, 20 miles in is just going on your hips instead of your butt where it's supposed to go. Yeah, so I think that's what causes a lot of like IT band syndrome and lateral hip pain in runners.
Yeah, for sure. Running is, you think, okay, well, I'm just going line there. That's the plane that I need to train in. And like I said, you have these muscles on the outside of your hips. Niraj mentioned it earlier, the hip abductors, lateral muscles that's keeping your pelvis level. And so if those get weak and pelvis lifts up on one side, and all of a sudden your knee's taking this sharp angle to the inside, that's going to put more compression both up at the top of the hip and down at the bottom as well, right? So you're absolutely right that that's one of those root causes that needs to be fixed. And again, going back to the foam rolling conversation of is it right or wrong? I think it can be, if it's being used to help with some acute pain that allows you to decrease pain so that you can go and work your muscle in a larger range of motion to fix a root cause, then I think that's a great way of utilizing it. But if you're using it as kind of the way to cure your IT band pain, it's probably not going to be very effective in the long run or the long term.
Right. Yeah. That your explanation makes perfect sense, because after my last marathon last year, I did 2. Bob checked me out and my pelvis was elevated on that painful side.
Mm-hmm.
So then, I'm stretching it out. And now it's a lot better. Plus, I'm not running like that much anymore. But yeah, it's all linked.
Yeah.
Which is it's kind of sad, because a lot of people like you and other PTs been working with are looking at the body as a whole instead of like just treating individual areas.
Yeah, I think it's in the questions too is, once we see somebody in clinic, so somebody checked you out after the marathon, is your pelvis elevated because in response to some of the pain you were having, and there's some compensatory shift or pattern because of the pain, or did that lead to the pain? And sometimes we don't know because we didn't have it before and after, right? But we get to treat what we see, and so you do attack it, you do adjust it, and usually that's lateral hip. And I think to touch on like shuffling versus springiness, I think we have to be like also very careful what we relate cadence to in terms of springiness or shuffling, because some athletes, who myself not included, who just are very athletic or came from a different background that are running, that you just see them and they're just like, they're almost like jumping along, and they're just have a lot of this, like what RT talked about, kind of this up and down, but it's not coming from just their calf, but they've got a very low cadence versus somebody who's shuffling and has a higher cadence. I think I say that to mean cadence, a higher cadence typically will offload the knee. So we don't want somebody like bouncing up and down crazy, but we do want somebody who isn't also just dragging their feet and has no flight time, right? So there has to be this kind of in between, which is what I think RT was getting at too.
Yes.
Yeah, and you're talking about more like people that translate vertically versus forward, propelling themselves running, right?
That's what that's the point I was trying to make, is someone who's propelling forward versus someone who's bouncing up and down.
All right, let's get, since we have been talking about hip pain now, we'll get on to the hip pain subject. So what approach, we'll say lateral hip pain, because if someone has like groin pain, that's the hip sockets. We'll say outside hip pain. So what approach do you guys use? I'm assuming it's kind of similar to what we're talking about for IT band.
Similar. First, ruling out a stress fracture, right? You want to talk about high risk areas that if you've got a stress fracture in the area, it needs to be addressed quickly, right? So I think first thing I'm doing there is trying to rule that out. So go, that subjective evaluation, that subjective data that you're bringing in, is, you can't put a price on it. It's so important when it comes to lateral hip pain kind of stuff. Say that all goes well and you clear that out, then it's a matter of going through, the exams that you learn as a student in PT school, and some stuff that you pick up along the way, which is, what is your hip range of motion, internal to external rotation ratios, or total hip range of motion, and then has that hip and has that tissue been stressed in each of those planes, right? You may have a really strong glute max, but if I ask you to get into a side plank, you can't hold it for more than 2 seconds, right? So super strong in one direction, but you have no ability to stabilize in this plane right here, right? So then it's a matter of, well, let's find a way to progressively load that tissue if it's muscular related, and build up that resiliency so that it can tolerate longer runs and faster runs and different surfaces that you're running on. That's if it's from a muscular standpoint. A little bit different if you're dealing with like a FAI or like a labral tear or something like that. But still, then again, goal is probably going to be initially, let's stabilize the hell out of the entire joint and go at it from that approach.
So you guys do more like isometric strengthening with hip abductor stuff then?
RT does a good bit more than I do, and I think it's really effective. I don't know why I haven't picked up on it this much, but RT does a good bit. When you talk about lateral hip pain, I think what you had mentioned earlier was also kind of this glute med or glute min tendinopathy at the lateral hip. And so, yes, of course, the subjective history is, like RT said, is gold. I mean, you can't shortcut that. And when it comes to rehab, you also can't forget some of the things that we talked about before, like this crossover gait may be a factor. I've spoken with people who are like, I sit all day, and they sit with their legs crossed, right? So you go out and run, and you train, and you do the right things. You side plank, you do your lateral step down and all these things, and then you sit for 6 hours with your leg crossed, and you're just kind of pulling at that tendinopathy and serving to just make it sensitive and irritate it, right? So little things may matter too, but I think what RT talked about is loading that tissue. We know that tendinopathies, tendinitis, what you may call it, respond really well to us challenging the tissue. So whether that be by starting with side-lying hip abduction and then moving into a standing hip abduction, and then a standing hip abduction with some resistance, and then lateral walking with a band or a lateral toe tap, and then into a side plank. You have to progressively load that tendon. And also, when you think it's good, that's when you've got 2 or 3 more months of work to do, right? Because as we know, as soon as it starts to feel good, all of us stop doing what got us there. And the nature of tendon is not that it has, it hasn't restored its normal properties. We know that the collagen, being a major player, is degraded a bit when you start to experience those symptoms. So I think setting expectations is something that we try to do well. Is that, look, I'm gonna, maybe we'll get you to where you're running the volume and intensity that you want, but I'm going to see you back in this clinic in 3 months if you think that you're going to stop doing your exercises and be okay, because lateral hip pain, tendon-related lateral hip pain takes a lot of work.
Yeah, I would say it's annoying because it never hurts you when you're doing the exercises or the running. It's that night when it hurts, when you're trying to go to bed. Yeah. And it's just like, oh, I overdid it, and then I think I'm good, and I try to do something harder, and then I'm back to square one for like a week.
Yeah. I mean, tendon pain is very much of that nature too, right? You have 3 good days, and then all of a sudden you're hurting, and you don't know that you did anything different. And I don't know that there's a great explanation for those. I'd be making it up if I said it, but I think that's just the nature of tendon rehab, is that it's very up and down. The trend should be that it's getting better if you're doing the right things, but you're still going to have those days where you just are pissed off because it hurts, and you don't know why.
Do you guys depending upon someone's, if they're anteverted versus retroverted, meaning for our listeners, the way their femur sits in their hip sockets, if it's forward or backwards, do you guys look at their gait and just kind of let them do what they naturally want to do with that, or do you try to change it?
Yeah, I I think that there are lots of things that we don't know about the hip, but what we do know is that anatomy can be very different from person to person, and even within, Mike, you may have two very differently shaped hips, the acetabulum and the size of your femoral head, and the angle of your femoral neck may be different from one side to the other. So when we see people with, kind of this windswept pattern where like both feet are turning one way or the other way when they're running, or they're very toed out or something like that, the inclination may be, well, that just looks weird. Let's get it straightened out. And I think that's probably one of the last cues that I'm going to use as a Hail Mary, if nothing else works. I think that people kind of selectively move into these patterns based on their anatomy in a lot of ways. And we're not going to change your anatomy, so we'll probably just create problems if we try to quote unquote straighten you out.
Yeah, when I was in PT school or PTA school, I was taught, you should walk with your toes ahead, and I'm naturally somewhat retroverted.
Yeah.
And so I started running that way later on, and then I'm like, now I have these injuries, and I was talking to PT, and he's like, why are you putting your toes straight? He's like, you sit down, you're retroverted. He's like, quit walking straight. He's like, you're screwing up your own anatomy. And I was like, oh, it's like I never thought about this.
That's one of those things you have to respect and be aware of too whenever someone's lifting, right?
Yeah.
Weight training as well, like you were saying, right? You're not going to go in and that you have this much more open space to get into a deep squat when your feet are pointed out a little bit. So talking about for you personally, you're not toeing in whenever you're getting in there and squatting, because then you're just kind of jamming in on that joint, right?
Yeah. So
that's about the only time where I'm making active suggestions on kind of foot placement and angles and stuff like that. But for running form, rarely am I changing the form necessarily. I'm letting that be a result of the mobility and the strength training that we're doing, and kind of letting the running form fall in line afterwards.
Okay. Well, do you guys have anything else to add on hip pain?
It's kind of those giant broad ones that we could probably sit here and do a long talk on a lot of different diagnoses on it, but no, not in particular. I think we've hit on it time and time again, is that subjective history is such an important thing when it comes to running related injury, and honestly any kind of rehab in general, because a lot of times the pain that you're having in one place is a result of something that's happening someplace else that a lot of times that patient or client has kind of disregarded as a secondhand thing, but is a really valuable piece of information that needs to be addressed and needs to be fixed in order to unravel kind of that entire knot that's causing the issue that they're having at the time.
Sure. Well, thank you for joining me today, gentlemen. You can find them at thestrideshop.com.
Thanks, Mike.
Yeah, Mike, thanks for having us.